Hey, so we will have Clarence there. Yep. To all the audience, Dr. Clarence Lei is one of the most senior urologists in our country, Malaysia. So I think most of us have been a student of his, right? So he is our chat GPT before chat GPT exists. Anything we're not sure, we ask him. Yeah. So he is the master. Yeah. So he now practice in Sarawak, Kuching, and today he will give us a talk on managing nocturnal polyuria in elderly BPH. Very common patient, yeah. Type of to screen show, yeah.
This year, 121
Yeah,
people.
it's all there. It's all there. Clarence.
121 people can see my presentation.
Well done. Let's go.
Okay. All right. Thank you, Prof. Ong. So I have been asked to share some practical insights into this problem of nocturnal polyuria. And what I will do is I will give my take and I will confess to what I do with my patients. How about that? Okay. So the definitions have been gone through by the first speaker, but it's just for me to say that desmopressin or vasopressin actually works on the kidney, not on the lower urinary tract or the prostate or the whatever mediators in the lower urinary tract. Now, I will give you my figures, and we published this in BJUI, that in our study in ASEAN, that we have 64% of patients coming to the urology clinic with nocturia. And of course, you have to stratify this into whether they have 1 episode, 2 episodes, or 3 episodes. And it's more common in the elderly people, but it's common in all ages. And it's generally said that if you have more than 2 episodes, it is bothersome. So it is the commonest and most bothersome symptom. But unfortunately, my experience is that it is the least treated. Most men will get treated for BPH, and women will get treated for OAB. So like any other medical condition, you must always take a history. You must always examine the patient. You must do baseline investigations so that you can arrive at the appropriate diagnosis, and you must treat other causes of all obvious causes of nocturia. The bladder diary is supposed to be useful in all cases of patients with urinary symptoms. And you have to measure the bladder volume, the intake, the output, and in older people, if you sleep 8 hours, your output should be less than 1/3. Of course, in younger people, they can concentrate the urine better. But I think it's not easy to have a full bladder diary. So I use a modified bladder diary, which is to measure the urine output. So the patient passes urine at night, and they measure the urine over a few days. And I also tell them in my practice, when you wake up to measure the urine, please measure your blood glucose. And this one such patient, he said, my glucose is very good, but at night, the glucose goes up to almost 10. So that will be a very obvious cause of the nocturia and nocturnal polyuria. In an international study published many years ago, it says that most men with nocturia has nocturnal polyuria. What about in Malaysia? In Malaysia, we have this Dr. Yung in Johor Bahru. He also published it, and he says that his patients, 85% of them have nocturnal polyuria. And therefore, these patients will not respond to alpha blocker therapy. In fact, the writers go as far as to say that you don't need to do a bladder diary. Yeah? You can give them empirical treatment because it's such a high prevalence. So it's for you to decide what you want to do with the patient. Now, some urologists will say, I can do a TRP. And in some patients, the nocturia and nocturnal polyuria will improve. Similarly, you get the alpha blockers, some of them will improve. So is that true? I think there's probably some truth in it, especially if the nocturia is due to poor bladder emptying. But that's what I say. That's my take on this issue. So the urologist can justify doing a TRP for nocturia. But I think you have to warn the patients that if the main symptom is nocturia, then we have to warn the patient that quite often the nocturia will not get better, especially for the younger, very keen urologists. So this is my personal series. I analyzed it last month. Since then, I have 2 or 3 more patients. These are my patients taking Nocdurna now. They have overlapping diagnoses like prostate enlargement, overactive bladder, ED. I have 3 patients with cancer, but they are in remission. They have nocturia, and many of them have associated medical conditions: diabetes, coronary artery disease, epilepsy, sleep apnea. Is often a problem of cause and effect. whether it's due to the medical condition given nocturia, but I think it's important to treat the underlying medical condition as well as the nocturia. So if the underlying medical condition is already optimized, then I think you have to treat the nocturia from the urological point of view, which is giving the patient Nocdurna. In the community, these are the so-called BPH clinics or family clinics. A lot of patients have taken nocturia. In this one case I picked up recently, nocturia twice, satisfactory urine stream, but the patient is given finasteride instead of the appropriate lifestyle advice, or to be given desmopressin. So I think there is a very low community usage of desmopressin. Whether there's a low awareness or not, I'm not sure, because people may be aware of this particular medication, but they're very scared to use it, or maybe it's too expensive. So this is my typical prescription. I give the patient treatment for the BPH. I also give them desmopressin, and I give them for 3 months. For 3 months. But the background to this fear of using desmopressin, I think, is from the usage previously of using Minerin 0.1 milligram, and the patients got severe hyponatremia, and they get admitted to the medical ward or to the emergency department. The sodium is 120, and the physician will give them fast infusion of sodium. And what does that cause? That can cause pontine myelinosis, CPM, and this can cause paraplegia. In fact, I have a patient, I know him, he became paraplegic after taking a few doses of Minerin. Luckily, it wasn't from me, and he remained permanently paraplegic. So hyponatremia, if you correct it very fast, can be a dangerous condition. Okay, so this is the new drug, Nocdurna, 50 micrograms for men and 25 micrograms for women. So notice that the medication desmopressin is gender specific, and earlier on, Dr. Warren Low talked about high dose insurance. So the metabolism of desmopressin in children, in pediatrics, is given for nocturnal enuresis, is a very high dose. So they are used differently in children. Okay, this is the product. This is the earlier form. This is called melt. That means you put in the mouth and it melt. Actually, it's not so easy to remove it. It's not so easy to remove it. You have to have quite sharp fingers to peel it open. And melt, that means you put into the mouth and it melt. Whether you put it on the tongue or under the tongue, I don't know. This is the index patient. You put it on the tongue. And it's to be taken without water. This is melt. But the new formulation is called Nocdurna. It may sound quite simple to you, but some people, in fact, some urologists still think that maybe you should take it with water. No, you put it under the tongue, or to me, on the tongue. And after a few, maybe 1 minute, you'll be completely dissolved and go straight into the bloodstream. So you don't need to take it with water. Okay, so this to me is the most important slide, because this is the drug insert. I take this from the drug insert, which the patient can read, and also the family elsewhere can access on the internet. And it says here very clearly, women 25 micrograms without water, men 50 micrograms, and it's not recommended to increase it. Not recommended. Of course, earlier on the speaker said that you can increase it, but it's off-label use. And you have to check your sodium before treatment, and check the sodium 1 week after treatment and 1 month after treatment. Now, it doesn't say when you check the baseline. You could have checked it 1 year before. No, I think basically, to me, within 3 months is fine. But although usually I do it before I start the treatment, within the last one or 2 weeks. And if it doesn't work, then you should stop it at 3 months. And if the sodium drops to 135, you have to stop the medication. Okay, so this is in the drug insert. This is legal. If you don't follow this, things can go wrong. So how do I handle my patients? I give them a prescription. They can go and buy it anywhere they like. And I tell them very clearly, and to the family, that they have to restrict the fluid 1 hour before and 7 hours after the administration of the medication. And they must check their sodium. Of course, if they have a prostate concern, I add on the PSA as well. And they must check the sodium 1 week and 1 month after that. I give them a piece of paper. They can go to the nearest laboratory to have it checked. And if the patient is from my hospital, they don't have to come and see me at 1 week or 1 month. I give them medication for 3 months, because I will automatically get the lab result from my own lab. They don't have to come and see me. Now we also have telemedicine. We've got many labs everywhere in Malaysia. In fact, every street you can see a medical laboratory, and they can go and get it done, and they will WhatsApp it to me or email it to me. So I use telemedicine to follow up on these patients taking this Nocdurna. They don't actually need to pay a clinic visit. The most important outcome to me is that taking this medication will increase their first void to 5 hours. So for example, if they have Nocturia 3 or 4 times, now their Nocturia may be twice, but the most important thing is that they can sleep for 5 hours before they wake up to pass urine. So they'll tell you they are very refreshed after taking this medication. But if the sodium drops to 135, then they have to stop the medication. So I have this patient, this is one of my star patients. He took it, I think in the beginning he started with melt, then he changed to Nocdurna, and the sodium dropped to 130. So he is asymptomatic because we pick it up early. So I just asked him to take more salt in his food and to repeat the sodium and continue with the duodat. Now, he liked the medication so much that he said, look here, I will take the medication with increased salt in my diet. He said, I take half a salt a day, and he's only 62 years old. But unfortunately, the sodium dropped again, but this time it dropped to 133. So if you follow the instruction from the drug insert, he will have to stop taking the Nocdurna for good. But I don't know, maybe he's secretly taking it with more sodium and checking his sodium every month. So this is my last slide to keep to time. So the EAU guidelines of 2024 has an indication for using desmopressin for men under 65 and even for men above 65, but it has to be low dose, low dose. And low dose, 50 micrograms, in my mind, is very, very safe. That's why I dare to give them 3 months supply and ask them to monitor the sodium, and I get the results from the laboratory. But you have to monitor the sodium right now. Right now, the guidelines, it may change in future. Right now, the guidelines say you must check the hyponatremia at baseline. EAU say baseline. The drug insert doesn't say when. Day 3, day 7, 1 month. And I think most of these patients would be checking their sodium at least once a year. So I think this is a very, in my personal experience, this new formulation, this new drug is very safe to use in men with BPH, so that we are more effective in treating their lower urinary tract symptoms instead of just treating their BPH or their OAB. Thank you very much, Mr. Chairman. This is my conclusion slide.
Thanks so much. This is very clear, and with very good patient history presented just now from Sarawak. So for the knowledge of the audience, Dr. Clarence Lei see various kind of patient there, and then he keep a kind of a compilation of a good case example. Yeah, and of course we'll hear more from him in the future talks. But we'll bring everyone back here. Yeah, thanks for the thanks again to Clarence. So I mean, while Clarence is here, we'll go to the Q&A now. But since you just now said low dose, so can the male take the 25, the female dose first? What do you think? The male is Nocdurna is 50, right? 50 microgram for male.
Brief answer is no. Brief answer is no.
No. Why no? Why no?
We have to, Professor Ong, we have to go by evidence-based practice, right?
Yeah. But I mean,
so the evidence done by the company is 50 milligrams. So you have to go off-label.